Good afternoon. This is Barbara Brandt, Director of the National Center for Interprofessional Practice and Education. And today we are, our Accelerating Initiative webinar is from Oregon Health and Sciences University in Portland. And the title is Reaching Rural Residents with IPE, or R3 IPE. This slide is for those of you who are applying for interprofessional continuing education credit and the groups that are being accredited. And the next slide is the speaker's disclosure slide, and we have none for this event. As always, I am facilitating this webinar with Carla Dieter, who is the coordinator of the Accelerating Initiative program and the coordinator of Nexus IPE programs in the National Center. And today's speakers from OHSU are Peggy Ross and Virginia Tilden from the School of Nursing, and Molly Osborne, who's a professor in the School of Medicine with the Portland VA. So after this webinar, these are our learning objectives, is to discuss how Nexus IPE team was able to implement what we call a Nexus, or an academic practice partnership, describe how a team of students and health professionals actively learned and worked together with people to improve health and well-being in the community. They're going to discuss key lessons learned, and they're going to describe, as our other webinars, how they use some of the learning tools to support the success of their program. Carla?
Yes, so we have explained this in previous slides, but we want to always emphasize this again. In 2016, 4 private foundations came together: the John A. Hartford Foundation, the Robert Wood Johnson Foundation, the Josiah Macy Jr. Foundation, and the Gordon and Mitty Moore Foundation. They came together came to the National Center with a vision to advance the 2010 Future of Nursing Report, which outlined major recommendations for the role of nursing in the development of leadership and the emerging collaborative care models. So the Iom Follow-Up Report in 2015, assessing the progress on the Iom report and future of nursing progress in the implementation of the 2010 recommendations, were both strongly highlighting the need for interprofessional education in settings other than acute care. So these partners supported the National Center to coordinate a one-time program, which was the Accelerating Interprofessional Community-Based Education and Practice Initiative. The program was open to all schools with graduate health, professional, and other non-health related professional schools, and who were committed to developing an innovative, ongoing core interprofessional clinical initiative in a community-based setting. So there was a national call for proposals. 16 schools of nursing were accepted. Many of them were advanced practice nursing leaders. They were in true community settings. It was a 2-year cohort. The cohorts received $50,000 plus significant technical assistance from the National Center for over the 2-year lifespan. Many of the sites continue working with us. The sites also needed to match $50,000, and many of the sites obtained their match from their community partners. The Institute, the tools, the site visit, and affinity group calls were part of the assistance. So they started off with a week-long institute in Minneapolis, and then we implemented many tools throughout their program to help them in their work. And they agreed to work with an external evaluator, which was Harder & Company. And we do have the Accelerating website noted there on the bottom.
So this is the webinar in one slide, and then I'm going to turn it over to the OHSU team. The front end of this slide is about this concept of the nexus, or redesigning both healthcare education and healthcare delivery simultaneously to be better integrated and more interprofessional while demonstrating outcomes. You will hear this team talk about their student teams making home visits to address the social determinants of health, and specifically about interprofessional preceptor competency development. The lessons learned are many from this site about building upon previously relationships, how senior leaders and university commitments contribute to the success, and the value added of student teams. And then they will discuss their value added outcomes that are on your screen. So I'm going to turn it over to the OHSU team, and we're happy to hear from you today.
Hi, good afternoon. We're happy to be here too. So just to start off, we wanted to acknowledge that we were guided by these 6 characteristics of a high-functioning nexus in designing R3. So we call it R3. So it's R3 IPE, but we fondly call it R3. And in designing this, the model was really helpful for us in setting up the project for success. So I think each of these characteristics are really important. Next slide. These are the academic community partners that participated with us in this project. First of all, the OHSU Campus for Rural Health and Cascades East Family Medicine in Klamath Falls, Oregon, and I'll be talking a little bit more about those as we go forward. And we had students, participating from across the university who were in their rural rotation in Klamath Falls from the FNP program at the School of Nursing, the School of Medicine, the PA program, and also from the College of Pharmacy. We built R3 on the scaffolding of 4 existing OHSU programs. First of all, the University Ipe Initiative, which was implemented in 2014 and is ongoing under the tutelage of a faculty-led steering committee and supported strongly by the Provost's office. So at OHSU, all students take a required foundations course that's focused on safety and quality. We have IPE electives that students can take from across the university, and then we also have various groups working on interprofessional clinical curricula, such as the R3 project. The Campus for Rural Health was another one of our foundational partners. So Oregon is a very rural state, and OHSU provides healthcare across the state. We say across the 96,000 square miles to rural residents and communities. And again, I'll talk more about that. ICANN is another project that we used to build R3. And ICANN is the Interprofessional Care Access Network, which was an innovation incubator project with the National Center that focused on social determinants of health and vulnerable people and populations. Cascades East Family Medicine is a rural family medicine clinic in Klamath Falls that's affiliated with OHSU. And then finally, R3 was able to take advantage of the experience
Peggy, this is Barb. We've lost you.
Oh.
We can hear you.
We can hear you now.
Thank you. Could we have the next slide, please? There we go. So just a little bit about the OHSU Campus for Rural Health. The goals of So the Campus for Rural Health is not a brick and mortar entity, but exists across the state in three sites to date. The goals are that we advance the health of rural communities in Oregon, to create an interprofessional workforce that's competent to improve health of our rural populations, and then finally to assure quality healthcare delivery systems and rural health environments. So students who participate in the Campus for Rural Health are housed by the university at these sites for 1-month rotations. As I said, there are 3 sites, all located far from the population center in Portland, as you can see. So Portland is way up on the Washington border over in the upper left-hand corner. And all 3 sites here are located several hours from Portland, and some are actually fairly difficult to get to by plane and car. So Klamath Falls, which is the location of R3 IPE, is way down at the bottom towards California there in the smallest circle. Klamath County has a population of 67,000 people with an average of 11 residents per square mile. So it's very rural and it's frontier in many parts of the county. As a result of the decline in the timber industry and the 2008 economic crisis, Klamath Falls was mightily affected. So 1 in 5 residents lives below the poverty line. There are high rates of unemployment and substance abuse, and there's been significant rural brain drain since 2008. About 50% of adults have a chronic health condition, and Klamath County is a health professional shortage area for primary care, mental health, and dental. However, Klamath Falls is also more recently a hotbed of community action. So in 2012, they formed what they call Healthy Klamath Coalition. They completed a community assessment, and they're trying to reinvent themselves around recreation, tourism. There's a military base there, and also renewable energy. So those are 4 industries that they're really working on, and developing community initiatives around wellness, food insecurity, public safety, and high school graduation rates. Healthcare is becoming the largest employer, and we have a significant presence there, and in fact are just this week opening a large educational building in partnership with the healthcare system down in Klamath Falls. Okay. I just wanted to say a few words about ICANN, which was the Innovation Incubator project that also provided some of the foundation for R3. So ICANN is a nurse-led model for healthcare delivery and interprofessional education that focuses on disadvantaged and underserved people and populations in 6 urban neighborhoods and rural communities across Oregon. So we started with 1 neighborhood in 2013, and we're working on developing and implementing our 7th site in LeGrand this academic year. So LeGrand is another very rural and frontier site. Okay. Cascades East is our clinical part for the program that we were trying to do. They're also the site of an OHSU rural residency program for the School of Medicine. And the smiling faces around this sign are a PA student on the left and 2 family nurse practitioners on the right. And we'll talk more about students' teams later. Okay, this is our compelling vision statement. And I don't think that I need to read through it, but it really captures the key focus of our vision for R3, focusing on adults in rural
Peggy, we've lost you again. Peggy,
Okay, are we back?
we are.
Okay. Okay, next slide, please. Okay, these are the R3 IPE team members. I'm Peggy Ross, the PI on this project. Ginny Tilden is a co-PI with me, and then Molly Osborne functioned as the co-I and evaluator on the project. At Cascades East, there were two key roles. One was the interprofessional preceptor who helped the students select patients and debrief students after their team home visits. And the project coordinator who worked with orienting the students around home visiting, huddled with them and reviewed patients before their home visits and helped them to make a plan before they went on home visits. And she also accompanied the student teams on home visits. And then there were several other people with whom we could not have done this project without, and they're listed there also, just around the logistics and the communication in the small rural town that we were working with. Okay, so this is what we did in R3. We engaged students who were in their family practice rotation at Cascades East. So these could be family nurse practitioner students, medical students, PA students, or pharmacy students. They worked in teams of various combinations of those students depending who was in the rotation. They were oriented to the community and then identified with the case manager and preceptors older adults for home visits. The students huddled with the coordinator to plan the visit, identify roles, and then they all went on a home visit for assessment and care coordination. They did a debrief with the interprofessional preceptor, documented in the EHR, and then updated the plan of care. So they really were out in the community figuring out what was going on with clients who had difficult health issues, and then came back and updated the plan of care to provide more efficient care.
Next slide, please. So this is Ginny, and I will walk you through the profile of students. So between spring of 2017 and the end of the project in December of 2018, we had 38 students assigned to Cascades East who were assigned in 4-week blocks each. And we had a total, therefore, of 13 student teams who did home visits. And you see here on this slide the breakdown of PA, medical student, FNP, and farm students. We took advantage of their already being assigned to their campus of rural health rotation. And so we took what we could get, and you see the distribution there. You see that the majority were female, and on age range that 87% were under 30, so these are very typical students, as you can see, and everyone was under 34 years of age. In the program, they were all what we might consider upper-class men and women. Obviously, they were all graduate students. The FNP and the PA students were level 2, so they were second year of their master's program. The medical students were all third year in their program, and the farm students were fourth year in their program. Most of the students made 3 or 4 home visits during their 4-week rotation. That had been our hope, that student teams would make a visit each week of the 4 weeks. It wasn't always possible. Some were 3, and some were only 2. Next slide, please. Let me apologize for my voice. I'm getting my winter cold out of the way early. This is a profile of the patients whom the student teams visited. So a total of 48 patients in the area or clients in the area had student team visits. And by definition, those patients who were eligible for this needed to be over 60 and to have 2 or more medical conditions, one of which was considered unmanaged. We left the social factors to sort out as they would, but as Peg has already pointed out, the demographic of this area is that it's a very high rate of adverse social determinants of health. And as I go through the boxes here on this slide, you'll see that that plays out. So age, you see that 60% were over the age of 70. Gender was pretty equal, male and female. Race ethnicity reflects the regions, 90% white. Social isolation, and by the way, we had pretty strict definitions for each of these labels. Social isolation meant limited or no contact with others for more than 1 week at a time, so 17%. Complex social, we defined as 2 or more social problems, and we had given our RA a list of what these social problems could be, and they included things like inadequate housing, food insecurity, and poor transportation. 54% had mental health or addiction issues, meaning recent or current treatment for 1 or more mental health conditions. Financial stress, 50% of our patients met this criteria, and this was defined as a combination of low education and low or unstable income. And frequent calls to EMS or visits to the ED was 48% of these patients. 2 or more, and this was defined as 2 or more 911 calls, ED visits, or hospitalizations within a 6-month period. Next slide goes back to Peggy now.
We had several barriers right at the beginning of this project. But fortunately, we were able to get beyond them. But still, we started late and had to overcome these things with a lot of help from our friends as we negotiated the issues. So first of all, the initial partner that we had, who came to the Accelerating IPE kickoff with us and helped to do the planning, withdrew from the program. So we had to find a new clinical partner in Klamath Falls. But as luck would have it, we believe that the partner that we wound up with was the best partner for us, in part because of their connection with OHSU and the Campus for Rural Health, and also because they had a philosophy of home visiting that they worked with. So their values really aligned well with our project goals. We relied on our local and OHSU partners and the National Center to help us with a Plan B, which we really believe worked out for the best. Our initial project coordinator was not employed by Cascade. She was a doctorally prepared nurse with community experience from the community. And she resigned fairly early into the process, which again was, kind of
A
setback for us, right? So what we did was redesign the position to fit a care manager at Cascades each clinic, which actually worked out much better. So she knew the patients and providers, she had access to the health records, and frankly, when we had the new project coordinator, I think it greatly improved our process. So even our barriers, I think, really caused us to find some solutions that worked out well. And then the final barrier was just that Portland is a long way from Klamath Falls. So it's 5 driving hours or an airplane ride and 2 additional hours of driving. So, Carla and Barbara can attest to the distance between Portland and Klamath Falls as we did a site visit there. So we needed to stay connected. So Ginny and I did road trips to Klamath Falls, had weekly video conferencing, and then relied on email in between. So I think we were able to maintain pretty good connection with that team in Klamath Falls.
Next slide.
Just to say briefly that all of those leaders, there's a slide. So the slide about leaders should be up right now. There it is. And just that these leaders were all indispensable for helping us overcome those early barriers. And then we can move on.
Next slide, please. So this is a snapshot of a patient that we thought we would show you because it exemplifies, I think, in a really clear way, the kind of impact that these students and student teams had on these patients. We, with 48 patients, with the kind of complex social and medical situations they were in, you can imagine we had a lot to choose from. But we selected this one to show you because when the students returned to the clinic and reported out on this patient, the care plan for the patient changed immediately. Now let me explain why. This was an older female patient living alone, so she qualified for social isolation. She had various comorbidities, and she had a number of adverse social factors, including financial stress, and she had made frequent ED visits over the last 6 months. During the home visit, students noted depressive affect as they talked with this patient and spent well over an hour with her, going over her meds, going over her plan of care, and they were singularly impressed with how depressive her affect was. And also they noted, as she talked about her situation, possible suicidal ruminations. Oops, can you back up, please? Yeah, thank you. Then upon reporting to the interprofessional preceptor, the care management for this patient changed immediately and significantly. There was immediate follow-up with the patient. There was initiation of antidepressant medication, close monitoring by the PCP, and referral to social services. We could go on about how the students affected the patients and what we heard from patients and from staff about them, but we thought this exemplified the immediacy of the change in the plan of care. Next slide, please.
So the students were really out there making a difference, and in the last week of the 4-week rotation, we asked students participating in R3 to complete reflections, which were short essays describing their experiences in R3. And here are the themes that we pulled out of that qualitative data. So first of all, students learned about themselves, about themselves in relation to other healthcare professionals, and also about how they reacted when they were working as a team member. They developed themselves, felt like compassion and confidence in their ability to have a relationship with patients who were very vulnerable and other healthcare professionals. They learned the importance of allowing patients to talk and listen to their stories. So there wasn't, for the most part, a health history focus, so the students weren't asking questions for short answers, when they interviewed these patients, but really allowed them to allow the patients to be more in charge of the narratives, and they learned the importance of that. And then finally, they learned how to kind of balance how they interacted with the team, when to step up, when to step back. So they learned something about their own participation as a healthcare professional. Next. They also talked about learning from others, learning about other professions' perspectives from other people, the roles and scopes of other professions, what successful teamwork feels like. So, sometimes they had more successful visits than others, and many of these students were together for the entire 4 weeks, so they really improved in their functioning as a team in the home visits over the course of the term in the rural health area. They learned about the challenges of teamwork and how difficult it is sometimes to accept different perspectives. And then they also just came to value when everything fit together and everything worked. So, you know, when they had a productive visit where everybody contributed. So they learned to value that. Next slide. And then they finally talked about the benefits of their of doing R3 in a rural setting. So the idea that they could see patients in their home, many of them had never been in a patient's home before, and really came to understand the benefit of that and how they could gain insights into social determinants of health. They observed providers and partnered with providers in the rural setting, so learn more about rural health and rural medicine. They came to have a much better understanding about not just social determinants, but how those social determinants created barriers for health and healthcare. And then finally, they learned how difficult it is to practice healthcare, or how different. So the uniqueness of practicing healthcare in a rural setting.
Next slide, please. So I'll walk you through the quantitative tool that we used in R3. Peg has just presented the essays that students wrote, so that's our qualitative data. For the quantitative data, we used the ACE-15. ACE stands for Assessment for Collaborative Environments. And I wanted to briefly give you the background of the development of this tool. It was developed here at OHSU. And as Peggy just said, by 2014, OHSU had adopted a university-wide IPE program for all students in clinical programs, all schools. But 2011, 2012, 2013, those were planning years. And there was a lot of, many task forces, a lot of faculty engagement. And as we planned what our sort of infrastructure of IPE would be here at this university, we knew that we had a lot of competence among the faculty in teaching classroom IPE, in courses, IPE courses, in developing our foundations course, which is required for all students. Where we were more uncertain was how we would bring students together in the clinical arena for actual patient interaction, not in their silos, but in IPE teams. And we were influenced by these two reports, one from IPEC in 2011 and one from the IOM in 2012, both of which pointed out that a problem in IPE, once you get students into the clinical arena, is the lack of role models in high-functioning teams. Our provost at the time was very interested in this issue, and she urged us to develop some kind of assessment that could be used to determine those teams that are more ideal, on the more ideal end of the continuum in the quality of their teamwork. So we could think about and be more mindful of where we place students rather than in any clinical setting that will take an IPE group. So she charged us with the goal to develop a brief inventory or measurement tool that could be taken very quickly, not slow down, clinic operations. And we sort of accepted the challenge and proceeded. So Elizabeth Ekstrom is my physician colleague on this scale. And so it was myself and Elizabeth and a psychometrician, Nate Diekman. We dove into tool development, which for any of you who have done this, it's a long road of testing and more testing and refinement and the accumulation of psychometric evidence. And we ended up with a tool that is a single factor brief scale that measures teamness. We appreciated support from the National Center for Interprofessional Education and Practice because we were one of the Nexus Innovations projects. And what we ended up with in the end was a tool not only that could be used for this sort of rapid assessment, but much more than that. We learned that teams use the ACE for team reflection and for their own self-development. We know that the tool is often used to compare teams or to watch and measure team growth pre, post, and intervention or training of some kind. So the tools ended up being having multiple uses beyond what we originally were set about to do. So next slide, please. We've got a black screen here on our end for a moment. We should be on slide 28. This is the correct slide, thank you.
Peggy, we can't hear you again.
IOM definition of what makes up teamness, and those bullets there are what the IOM says. Shared goals, clear roles. I won't read them all, but they're easy to see there. Over much usage, many investigators have reported back, and the maximum score range is 15 to 60, and the mean range over many studies has been between 43 and 58. Next slide, please. And this slide shows you our pre and post with our students on how their teamness as measured by the ACE improved from week 1 to week 4. So time 1 is the big blue bubble on the bottom right, the lower right. You see the mean for the student group was 51. These students were really just getting to know each other. And in the instructions on time 1 on the ACE, we acknowledged that. The instructions said, you are a new team, you're just forming, we don't expect your scores on this tool to be high. But read the items and answer as best you can, and notice what the items are telling you about teamwork. So in a sense, we used it as an intervention to do a little kind of mental preset for these students about teamwork. On week 4, we gave them the tool again, and you see their mean had improved to 56.7, and that was a significant improvement. Take a look also at the standard deviations, which is the x-axis, and you see that the standard deviation time 1 was 6.6, so that meant that they were all over the map in their answers. We think that high-functioning teams have much smaller standard deviations. There's a lot more answers that are similar in high-functioning teams. So we were glad to see the standard deviation went down in time 2.
Okay, in addition to this is Peggy again, in addition to this student feedback, we had some feedback from the medical director and from the stakeholders at the clinic. So the other folks that participated at Cascades East. And they really considered R3 to be a very robust learning experience because the students were able to connect with patients in the clinic and then again out in the community in their homes and really get the full context of the patient's healthcare situation, which really allowed them then to focus on the care plan and develop that as a team. And the medical director really believed that this was exceptionally meaningful to their clinical learning when they were able to actually contribute and make a difference. They also indicated, again, as the students did, that the ability to assess social determinants of health barriers in the home environment was an experience that they hadn't gained in other courses or in other rotations. And then finally, their ability to debrief with the interprofessional preceptor really allowed for some deep learning and very productive conversations that again resulted in changes in patient care. Next slide. The key lessons that from IPE, from R3 IPE were, first of all, I think, to build on previous relationships and programs, and we felt that that we did a good job on that. To leverage senior leadership, the commitment of university administrators is key to the success of the program, as well as programmatic directors and partners added to the schools. Another lesson is just the value that was added by the student interprofessional teams doing the home visits and doing their assessments to extend the reach of primary care providers. So they learned so much about patients and the environments from being in the home. The patient and population outcomes were important to show value, including cost savings. And then finally, just that rural communities, have so much promise in terms of offering opportunities for partnerships and student placements. And, they can be inconvenient and difficult to manage, but I think they're really unique experiences. We definitely need providers in all areas of healthcare in our rural areas, and these rural opportunities, and they're really being able to be out in the community, meeting people and doing the work, I think made an impact on these students, and hopefully will result in more of them seeking out practices after graduation in rural areas. Sustaining R3, the elements of the program that were sustained was that the clinic model of home visits has continued with students going out to visit patients with nurse practitioners and case managers, physicians. So the students are still going out doing home visits with their preceptors, but not necessarily as an interprofessional team, unfortunately. Part of the project that was costly to the clinic had to do with offsetting the clinical productivity of the interprofessional preceptor and the case manager. And so they had concerns about continuing the model as it was without external funding. However, the model worked really well. It's scalable and replicable. The students made a difference. They loved their rotations and they loved doing the home visiting, felt that it was really core to their learning. And then, we have anecdotal evaluation of patient outcomes. And in the future, as we implement this, we know that what we need to add is systematic evaluation of the outcomes and the savings to this R3 model. Okay. Just briefly, in addition to the 6 characteristics of a high-functioning nexus that we mentioned earlier, other national center tools supported our work. The stair-step model helped us to track our projects. So we began at stage 1, and by the end of the program, we had achieved 5 stages to a significant extent. So the model was really helpful to measure our growth and support future team planning to focus on those higher steps in the model with community and cost outcomes. Next. And then finally, this IPLC model continues to provide guidance as we work on next steps for the development of our program on health and systems outcomes, which will support our sustainability. So Barb,
thank-
it's back to you.
Yes, thank you, team, and I'll take it from here. We have some questions that have come in, and so I want to encourage the people who are participating today to send us any questions that you have for this team. But I want to go back to the IOM model and pick it up from there. This is a model that many of you will likely be familiar with. It was in the National Academy of Medicine, or at the time, Institute of Medicine's report on measuring the impact of IPE on patient outcomes. And so collaborative practice, collaboration and patient outcomes. And so this model mapped out what are the types of variables that you should be thinking about as you take these IPE programs and design them for outcomes. And many of our sites in the accelerating program are documenting outcomes and to garner the resources that Peggy described are so needed to keep these programs sustainable. So in the next slide, we have taken this IOM model, which focuses on the design of learning across the continuum from foundational or pre-professional education, graduate education, or residency, and into continuing professional development. And now we very much encourage programs to start and to focus on that practice because it's so important to have the role models in practice. This is the reworked IOM model that the National Center has been working on, and we have retained the enabling or interfering factors, which is professional culture, workforce policy, institutional culture, and financial policy. We have retained the learning outcomes, or the Fitzpatrick model, but now we have been working on focusing on the quadruple aim. So the triple aim plus health and well-being of the provider. So we have mapped all of this work based upon our experience to understand what the variables are to these types of programs that we've been highlighting in the Accelerating Initiative. And we have identified a core data set. And the reason I'm talking about this in this particular presentation is, I'll say two things. One is we have chosen the ACE-15. It is a very easy instrument to administer with teams. And as you heard Jenny talk about for teamness, this is readily available on nexusipe.org in the evaluation section, along with the literature that supports the ACE-15. I also want to identify one other feature of the core data set. I won't go, and we will have a webinar on these in the future, is they experience a number of critical events, or what some people call barriers of IPE. So you heard Peggy talk about almost immediately they lost their key partner that they had been planning on. So we think that this is so important to track these types of events, as well as to track how you manage them. And so our core data set, which is now in an information exchange that we're getting ready to roll out, allows you to track this data and getting individualized reports. So we thought we would introduce this during this webinar because this particular team has been instrumental in our understanding many aspects of the core data set that we'll be rolling out. So I'm going to wrap this up and just help you. On here are the future webinars. We're doing one a month, and next month is Creighton University on January the 22nd. So with that, you can find us on our website. Many people have registered for the entire series. And this is the accelerating website, again, that many of you have been visiting. So I'm going to open it up to Q&A. And one of the questions that have come in, the first one I'll ask is, how did patients, families, and the community factor into your compelling vision? So what was it about, as you described the community, that drove the compelling vision for your program?
Yeah, hi, this is Peggy. We've had experience with that community because we have a nursing campus that's located in Klamath Falls. We have this rural medicine residency program in Klamath Falls, and it was a site for the campus for rural health. We also knew that the community was very underserved, and wanted. We had a lot of success with ICANN in making a difference. Students were learning a lot, and this was really a spin-off of that model to focus more with graduate students in the in a primary care clinic. So it was just a little different perspective that focused more on the healthcare plan and how students could contribute to that by extending themselves into the community as a team.
And this is Janine. I'll just add that in our statewide demographics and health statistics for the state of Oregon, Klamath and Klamath County is the poorest county in the state. It is a frontier county, meaning that the population per square mile is exceedingly low and under some definition between frontier and rural. But the health statistics are the worst in the state. So it made sense to us because, as Peg said, we had some infrastructure there already for us to in a sense, take our innovation to the county that needed it the most. I'll stop there.
Okay, we have a number of questions that are starting to come in. And so two of them are related. The first one is, what are the factors contributing to why teams have not necessarily continued to make home visits? And the number two is, could you say a little more about the philosophy of home visits at OHSU, and is it across schools? So you might clarify those two items.
So, I think that, in retrospect, I think that because this partner that we had, this second partner, which was an excellent partner, which is the perfect partner, but they came on late and had not helped with the planning of this project from the outset. I think that it was kind of an add-on to some extent. Even though they saw the value of it, they continue to include students in their home visits. I think the extra cost of the interprofessional preceptor and the care and the project coordinator made it difficult for them to continue the model. However, we're not giving up, and we are working with the steering committee on what's next. So this model, I think, works really well in rural, and we would like to implement it on the other two rural campuses, but it also could be replicated in an urban underserved setting. And then the answer to the second question about the home visiting is that I think it's fairly rare right now to have a family medicine practice that routinely does home visits, and I think speaks to the way that this rural health practice has taken into account the needs of the population that they serve. But on the other hand, OHSU is just completing a new strategic plan that we're calling OHSU 2025. And one of the tactics that will be included in that plan in terms of extending ourselves to the community is that the language that we're using is that a fourth campus of OHSU will be patients' homes. So there is, I think, a strong desire to integrate this model into education broadly, and yeah, so I think it's very cool. Yeah, we're really excited about it.
So this is Barb, and indeed I was in this site, and it is an airplane ride and a 2-hour drive up into a very gorgeous area. And the physician that I met gave an amazing discussion with us about how the students went into a home and actually saw something that she was unaware of in a condition that she had been taking care of a patient for quite some time, and really was very thankful because she had missed some things about that woman living in her home. So anything you could do to continue advocating for this, we will be there for you, because we got to visibly see this. So I hope I can get 2 questions in, but one is, great presentation. Did you encounter any professional licensing issues, either for site to team members, especially that screening can potentially lead to liability? Thank you again. Licensing issues, either for site or the team members.
Well, interesting question. It kind of reminds me of that thing about asking forgiveness later. We didn't encounter that question. It wasn't posed to us. The students, were placed by their programs in that setting. So all of that liability issue and so forth of student placements was worked out beyond us, outside.
They have oversight by the professional, and then Oregon has some progressive practice laws. I would say, yeah. I mean, so I would say that, from my optic, is how you manage this. I'm going to ask one quick question. We have a lot of followers of this webinar series from the AHEC program, and I know Oregon has a robust one. How were they involved? And then this will be our last question.
The director of AHEC helped us with the planning early on. He is a PA, very well regarded.
And
here.
a nurse. And a nurse.
Oh, he was originally a nurse, wasn't he? And then became a PA, and then got his PhD in education. So wonderful guy. And he was part of our planning and advisory group early on. There was no overlap between AHEC and R3. I don't even believe AHEC actually has a presence in Klamath. It's elsewhere. So there was no bumping up against each other. In fact, it was a very collaborative assistance that we got from him.
Right.
So I believe, this is Peg, I believe that when there are AHEC scholars in Klamath Falls, that they participate in ICANN. So they do some professional teamwork through that program, but they're not placed at Cascades East Family Medicine, and it was only those students who participated.
Right.
And I think that's important to underscore. Your institution is extremely supportive, interprofessional, and this was one project. And clearly, there's a lot going on, the ICANN program, the AHEC program, AHEC scholars. And again, what we talked about today was one program, which is home visits. And I hope that it gets back into your strategic plan. So I'm going to, we're bumped up against time. And I want to thank everyone on the call, and we will put out an email. You can access all these webinars, and people are doing it all the time. I want to thank the OHSU team, as always, and for joining us, and happy holidays to everyone. And from Minnesota, stay warm.
Thank you. Bye-bye. Bye.
Bye-bye. Thanks so much.